All right, today we're playing detective. We are diving into a really fascinating medical mystery, a condition that shows up with some, well, very strange clues. We are going to solve the case of the osteoid osteoma. So let's start with the central puzzle, the question that's really at the heart of this whole thing. Picture this. You've got this deep, nagging bone pain, the kind that wakes you up in the middle of the night. But then you take a simple aspirin, something you can get anywhere, and poof, the pain just disappears. So what in the world is going on here? This one clue, this is the key to unlocking the entire investigation. Okay, so our investigation is going to start by digging into the pain itself. Because this isn't just any old ache. No, it's the specifics of the pain that really point doctors in the right direction. Let's break down the evidence here. First, what people report is a deep, nagging pain. Not a sharp, sudden thing, but a constant, dull ache that just won't quit. Second, this pain has a very distinct personality. It gets way, way worse at night. And third, and this is the real telltale sign, it is almost magically zapped away by salicylates, which is the class of drugs aspirin belongs to, or other NSAIDs, non-steroidal anti-inflammatory drugs. And you have to understand, this reaction isn't just some interesting little detail. It's a huge part of the diagnosis. When a doctor hears that combination, nagging bone pain worse at night, but aspirin makes it go away, a very specific light bulb goes off in their head. It's a massive clue pointing directly at our culprit. So, with these first clues in hand, it's time to put a name to our primary suspect. What exactly is this thing that's causing all the trouble? Let's unmask it. And the culprit's name is osteoid osteoma. Now, I know the word tumor can sound pretty scary, but the most important word here is benign, which just means it's not cancerous. It's basically made of two parts, a tiny little core, always smaller than 2 centimeters, called a nidus, which is surrounded by this thick ring of dense reactive bone that your body builds around it. Here's a good way to think about it. Imagine that little nidus is like a tiny, rogue construction site inside your bone that's gone haywire and is just constantly active. So what does your body do? It builds this thick, bony barricade around it to try and wall it off. Now, this hyperactive little construction site pumps out huge amounts of inflammatory things called prostaglandins. That's what's causing all the pain. And it's exactly why NSAIDs, which are designed to block prostaglandins, work so incredibly well. Any good detective needs to build a profile of their suspect. Who does this thing usually affect, and where is it most likely to be hiding out? Let's take a look at the typical profile for an osteoid osteo. And the profile is surprisingly specific. This tumor usually shows up in adolescents and young adults. We're talking typically between the ages of 10 and 25. It's also much more common in males, and its favorite place to set up shop is the diaphysis, which is just the long middle shaft of bones like your femur or your tibia. And as you can see here, it has some favorite hideouts. While it can really show up in any long bone, its number one spot by a long shot is the proximal femur. That's the top part of your thigh bone right up near your hip. The tibia, your shin bone, comes in second, followed by different parts of the spine. Okay, so we have a suspect and we have a profile. But in medicine, a hunch, even a really strong one, just isn't enough. You need cold, hard evidence. So now we're going to look at the tools doctors use to nail this diagnosis down beyond a shadow of a doubt. The number one tool for gathering this evidence is the good old-fashioned X-ray. It's usually the very first step, and it's often the most important one. On that X-ray film, doctors aren't just looking for something weird. They are hunting for a very specific, almost classic visual pattern. And there it is. That's the textbook description you're looking for. A small radiolucent area surrounded by dense sclerosis. Let's translate that. Radiolucent just means the spot, the nidus, looks darker on the X-ray because it's less dense than the bone around it. And that dark spot is completely encased in dense sclerosis, which is bone that looks super bright white because it's way thicker and denser than normal. So this classic dark spot inside a bright white ring look, that is the visual confirmation doctors are searching for. It's the smoking gun. It's the absolute definitive piece of evidence that screams, yup, this is an osteoid osteoma. Now, if for some reason the X-ray isn't perfectly clear, a bone scan can provide even more proof. Because that nidus is so metabolically active, remember that rogue construction site? It lights up like a Christmas tree on a bone scan. It shows up as this really intense hotspot, which confirms all that activity and pinpoints its exact location. So, we've identified the culprit, we've gathered all the evidence. Now it is time to close the case.
How do we actually treat an osteoid osteoma and finally put an end to that bizarre nagging pain?
Well, there are two main ways to solve this. The modern, go-to treatment is called radiofrequency ablation. It's a minimally invasive procedure where a doctor guides a tiny probe right into the nidus and then uses heat to basically cook and destroy it. The more traditional way is surgical excision, where a surgeon actually goes in, cuts it open, and physically removes the nidus and a bit of the bone around it. But you know what? It doesn't really matter which method is used, because the goal is exactly the same. Take out that active nidus. Once that little rogue construction site is shut down for good, the source of the pain is gone. And for the overwhelming majority of patients, the mystery is solved and the case is closed.